and they looked at it in 6-year-olds. 6-year-olds myopia is a really, really bad thing because the risk of progressive and high myopia is 6 to 7 times greater. And so the percentage of myopes in 6-year-olds before the pandemic and after the pandemic, there was a 16% increase.
This is the Think Again podcast. I'm Scott Jens, your host. And in today's session, we're going to gain insights on how to completely commit to building a myopia management practice from someone who really knows the topic. Our guest is Dr. Dave Kading, a well-respected optometry podcaster in his own right, including Myopia podcast. And he also is CEO of his practice called Specialty Eye Care Group and the Mind Eye Center. Dr. Kading, welcome to the Think Again podcast.
Absolutely. It's awesome to be here. Thanks, Scott, for having me.
You're welcome, and thank you. As we start, tell me a little bit about how you've accomplished everything that you do. I mean, what percentage of your time is spent in your practice versus your many advisory efforts that you do in the profession?
Yeah, well, ever since the beginning, obviously the practice was a lot heftier and the advisor and the consulting was a lot less. But ever since, it was just something that I fit in between and throughout patient care and so forth. And so, yeah, I see patients on 2 days of the week and not for the full day. And I schedule even things in between there. And so, it kind of breaks down to it's all meshed together. I just recently listened to Walter Isaacson's book on Elon Musk, and I'm like, oh my goodness, this guy's running 7 different companies and they're billion-dollar companies. And I don't he never can say that he has this much devoted to any one company. It's just all spread and like where he goes where he's kind of needed or where he sees an opportunity to expand or improve. And not that I can compare myself in any way to Elon Musk, but it's just I move where is needed at the moment and focus more on the practice on some days or some weeks or some months, and then focus on my consulting. It just kind of goes in waves.
I was going to say microcosmic, but maybe it's macrocosmic of ODs and their practices, right? So we're talking about myopia today. There's so many different areas we can focus. I want to ask you about the pandemic and post-pandemic myopia surge that's happening. I mean, I was a myope, right? In 1997, I was a -4.25. I had PRK. My brother in the 1970s got to be a -11 despite having atropinization by an ophthalmologist wearing photo gray
Wow.
lenses and straight top bifocals. There was myopia in the past too, but it's surging. What's happening?
That's a really good point. The pandemic really kind of opened up some interesting perspectives around myopia management, particularly with regards to some progression. There was a study that was done in China, and in China they actually do large population studies every single year, and they look at the prevalence of different things at different ages. And one of the things that they looked at was myopia, and they looked at it in 6-year-olds. 6-year-olds myopia is a really, really bad thing because the risk of progressive and high myopia is 6 to 7 times greater. And so the percentage of myopes in 6-year-olds before the pandemic and after the pandemic, there was a 16% increase in the prevalence. And that means that kids turning 6, how many of them were myopic before, and then turning 6 after the pandemic, 16% more. So we know in multiple studies, this just being one of them, that the prevalence of myopia continues to increase. It was a small percentage of the U.S. population prior to 1970, and now we have it nearing 50% of the population, and high myopia being a substantial percentage of that and increasing considerably.
All right, that makes sense, right? The science is there. So we're talking about helping our audience think about making a full commitment into myopia management as part of their practice, or maybe even a service that is a substantial part of their practice. If you were to say what's the first mindset key for an OD to make this commitment to do this, what would that be?
Yeah, well, really, I don't think that you can delve into myopia management as a practice builder or as an added service that you might want to grow in until you have a complete belief. And that's a really difficult thing to say because everybody's like, oh, yeah, I don't want kids' prescriptions to be increasing. But what I really mean by that is physicians, it's our objective to reduce progression of disease. And if you don't think about myopia as a disease, then you're not going to be aggressive with treatment of it. I mean, Scott, you and I would never see a patient with, you know, uh, hypertension, ocular hypertension, and just say, well, let's see what happens. The studies are very clear as to what happens if you do not treat a glaucoma patient. And when it comes to myopia, we're still saying so often, let's see what happens. The evidence is clear, it tells us exactly what's happening. So, redefining myopia away from a refractive error into a disease where we're really, really pointing to the condition as being much more than a refractive error. I speak about myopia as being a progressive disease that results in eyeball elongation, resulting in higher risks of disease, blurry vision, and increasing prescriptions. So the prescription change is a result of the disease of eye elongation. So if an eye is elongating, our risks of diseases are way higher, and it is of itself a disease. Tissue change is a disease. And so if the mindset that has to change is this is a progressive disease, and if you are not treating it to slow it down, then just like any other disease, you're just being complacent and just letting it go. And that's just not a mindset that I think we can really be on board with anymore.
It almost feels like you created the mission statement that goes on the wall in the practice that's going to create a myopia management clinic that's of substance, right?
Yeah,
Um,
yeah. I
so,
hope so.
so, so with that, what about the person who says they can be the CEO of all seven parts of their practice? Do they have to give something up? I mean, do they have to commit to it fully? Can they do it and something else in their practice? What's your advice for somebody that's really going to build a service in their practice that's fully, committed?
Yeah. Well, when practitioners come to me and they say, hey, I want to start a dry eye center of excellence, I want to start a myopia management practice, I want to do these things in my practice. And I'm like, well, tell me about your practice. And they're like, oh, we got a 2 week waiting list. We see 15, 30, 40, 50 patients a day. Um, and I'm like, well, you just don't have the capacity to bring in something new like that to focus in on it because you're just going to continue doing what you're doing. You're not going to very easily make a shift. And so that's where the opportunity to bring in an associate doctor, that's where bringing in, additional staffing or a team can really bring that approach. But you will incredibly need to see more patient encounters if you're going to start doing myopia management. It's not something where you can just say, here's your contact lenses, I'll see you in a year. Just like with a glaucoma patient, you wouldn't hand them an eye drop and say, I'll see you in a year. There's monitoring of this disease to help make sure you're slowing it down as effectively as you intend to. So when it comes to adding it in, you need to have capacity in order to do so.
Makes sense. Let me talk about instrumentation. What are the baseline, sort of the table stakes that a practice should have if they're going to commit to a myopia management practice?
Yeah, the thing everybody wants to hear us say is that you have to add additional equipment, and you don't. You can just use the equipment that you currently have. If you're going to be doing orthokeratology, then obviously I think it's a good idea to have a topographer. But that being said, I was not a big advocate of axial length measurements until about 2 years ago. And the reason why, Scott, is because I didn't think that the platforms of axial length measurements were there yet. Most practitioners were utilizing an IOL master designed for elderly patients for cataract surgery and bringing that standalone device in. Well, you and I both know we have way more room in our practices to put equipment, right? We just have tons of rooms for it. We don't. So I'm a big advocate of when it comes to purchasing equipment to try to have it do multiple things. buy your next topographer with aberrometry in it, buy your with biometry in it. Sorry, not aberrometry, with biometry. Buy your next autorefractor with it included in there, and just demand that it's an add-on to another piece of equipment. So you can start myopia management, but when you're upgrading your topographer or you're upgrading your autorefractor, buy something that has additional devices in it. And when you have axial length measurements, it changes your mindset away from a prescription disease to an eyeball length disease. And so, if you're interested in doing myopia management and going all in, which I really hope people are, buying an axial length device is going to really catapult you, because we now do axial length on every patient, not just on pediatrics, but on every patient. And now I see that -7 patient who's got a shorter axial length than I would have expected. And I don't worry about their retina like I did before. And I see that patient who's a -3 and their axial length is way longer than it should be. And I'm like, hey, I need to educate you on, retinal detachment signs and symptoms of when I never would have thought of doing that on a -3. And so it changes your perception of all of these different aspects of eye care.
That's fascinating. I remember one time Dr. Ben Gaddy telling me about corneal hysteresis and its impact on IOP measurements. And until you get involved in this stuff, there's data you've never measured. You don't know what it means. In fact, as we think about myopia management, I'm wondering what kind of where does an OD that wants to go down and deep on this get training and resources, because they don't know. I mean, most ODs don't know axial length standards the way
Right.
you do. When you get a fully functional myopia management service set up, what is your recommendation on how to get that down and deep training and insight?
Yeah. Well, so first of all, obviously, general optometric meetings are a good place to kind of get started and get your feet wet. Beyond that, I think the Vision by Design meeting, which is put on by the American Academy of Myopia and Orthokeratology. I'm saying the name wrong, but the AAOMC is a great place. Obviously, GSLS has some workshops. We're putting on workshops. So I put on a workshop in Seattle for people who are interested, and it's a small group, 5, 10, 15 people, and we just talk about how to dig deep and put myopia management into place. And so there's some of those workshops that are popping up, and those small group things can be a really good way to learn quickly. And just like back in the olden days, my grandfather, he dedicated 2 weekends to going and learning about pharmaceuticals, because he didn't have that in his scope, and then he did, and he's like, okay, I'm going all in. I'm going to spend a lot of time, bring this into my practice, and implement it. It's one of those things where if you're not doing a specialty and you want to do one, you gotta dedicate some time to make it worthwhile.
That's great advice. Last word from Dr. Dave Kading on building a myopia management practice?
Yeah, something that's certainly able to bring into your practice. You've already got the patients that are in there, and if you're not doing myopia management for your patients and you're not sending them out, you need to do one of those things. This is not something that we can avoid anymore. The patients that are in your chair, fast forward 30, 40 years, will have progressive disease that is really an issue. And if we could go back, we would, right? I think about my patient, his name is Steven, and he's got all these retinal issues, and it's because of his progressive myopia. And I'm just like, man, if I could go back. And so every patient that walks in the door, I see Steven in my mind, and I'm like, okay, I have to stop this for this patient when he gets older or she gets older. So you have to intervene, whether it's in your own chair or you're sending it out to somebody who's doing it well.
Right. I think about my brother Eric wearing those glass photograde flat top bifocals in 1976. And
Yeah,
something was trying to control myopia then. And it's great to see scientists like you taking it the next level. Dr. Kading, thanks for being our guest today on this Think
absolutely.
Again podcast.
My pleasure.
That's it for today's Think Again podcast, brought to you by GPN Visions, a peer to peer learning community to help grow your eye care business.